Welcome to this explainer. Today, we're jumping straight into the clinical pathway for examining and identifying hernias. If you're a clinician aiming to nail those NMC guidelines, specifically demonstrating the absolutely correct technique to examine a patient and spot different types of hernias, you are in the right place. We're going to build those physical exam skills right now, from the ground up.
So you might be wondering, why are these hands-on skills such a massive deal? Well, because mixing up a simple, reducible hernia with a life-threatening, strangulated one, that can literally have fatal consequences for your patient. A strangulated hernia presents as an acutely painful swelling with actual tissue ischemia, and it needs emergency surgery, STAT. Your hands and your eyes are the very first line of defense.
Okay, here's the game plan to turn you into a true clinical detective. 1. Anatomy of a hernia. 2. Clinical examination steps. 3. Key examination checks. 4. Identifying groin hernias. 5. Identifying ventral hernias. And 6. Recognizing severe complications.
Section 1. Anatomy of a hernia. Understanding the defect. Let's get right into it.
You really can't examine what you don't understand, right? At its core, an abdominal hernia is just an abnormal protrusion of an organ or tissue pushing through an opening in the layer that usually keeps it locked in place. It's basically tissue rebelling and pushing from the inside out. And as it pushes outward, it drags all those coverings of the abdominal wall right along with it.
Structurally, every hernia has a few key ingredients. You've got the abdominal wall defect itself, the peritoneal sac that gets shoved into the subcutaneous tissue, the contents inside that sac, which could be bowel, omentum, or just fat, and absolutely crucially, the neck. Seriously, burn this one into your memory. The neck is the narrowest part of the defect, and it is exactly where things get trapped and cause massive, life-threatening trouble.
Section 2. Clinical examination steps. The investigation begins.
When you've got a patient in front of you with a suspected hernia, you can't just wing it. You need a strict step-by-step routine. First, examine them lying down. Second, you absolutely must get them to stand up. Standing increases the hernia size, and honestly, some hernias are completely invisible until the patient is on their feet. Third, ask them to cough or do the Valsalva maneuver to provoke it. And finally, if it hasn't popped back in on its own, try some gentle reduction. Though a quick tip, sometimes the patient is a total pro at this and can do it themselves with way less discomfort.
Okay, so you've done the steps, and bingo, you found a groin hernia on the right side. Here's a pop quiz for you. What is your absolute immediate next step? You check the other side. You have to check the contralateral side every single time. Why? Because occult or totally hidden contralateral hernias show up in up to 20% of patients. That means 1 in 5 people is hiding a second hernia you haven't even spotted yet. In fact, a patient with one hernia has a 50% lifetime risk of getting another on the other side. Always, always check both sides.
Section 3. Key examination checks. The clinical checklist.
Now, while you're busy moving the patient around and having them cough, your brain needs to be running through a rapid-fire checklist. You're checking reducibility and feeling for that expansile cough impulse. But you're also on high alert for severe tenderness or skin color changes. If you see overlying cellulitis, that means the tissue inside is strangulating and you're suddenly dealing with a major emergency. Oh, and don't forget to look for signs of previous repairs, and for male patients, always check the scrotal contents to rule out anything else.
Section 4. Identifying groin hernias. Inguinal versus femoral.
Let's zero in on the groin, because pinpointing the exact type of hernia here dictates your entire game plan. To tell an indirect from a direct inguinal hernia, you find the deep inguinal ring, right above the midpoint of the inguinal ligament. Apply some gentle pressure and have the patient cough. If your finger stops the hernia from bulging, it's an indirect or lateral hernia. But if it stubbornly bulges out medially anyway, despite your pressure, you're looking at a direct hernia.
Direct hernias are super common in older patients. They have a really broad base, which is good news because they're less likely to strangulate. But they can drag surrounding anatomy along for the ride. Check out this image. It's a cystogram showing a chunk of the urinary bladder literally pulled right down into a left direct inguinal hernia. Wild, right?
But what if you stumble upon a lump just below the inguinal ligament and it just doesn't act like a typical hernia? How do you tell if it's a groin hernia or just a swollen femoral lymph node?
This is a classic trap that catches a lot of clinicians off guard. Femoral hernias squeeze through the tiny femoral canal. Because they have this incredibly tight, fibrous neck, they often have zero expansile cough impulse, none.
This completely tricks people into misdiagnosing them as just a harmless lymph node. You've got to maintain a super high index of suspicion for any growing lump, even if there's no cough impulse.
Section 5. Identifying ventral hernias. Anterior abdominal wall.
Let's look higher up, starting with umbilical hernias. We see these a lot in overweight men or postpartum women. They usually pop out right next to the umbilical depression, and they create this really distinct crescent-shaped look right on the surface of the skin.
A bit farther up the abdomen, we hit epigastric hernias. These guys push straight through the midline raphe, anywhere between the xiphoid process and the belly button. They usually start off as tiny little defects containing just a bit of extraperitoneal fat, which kind of spreads out under the skin and ends up looking a lot like a little mushroom.
And then you have the giants, massive ventral or incisional hernias. These usually pop up after previous surgeries, especially if they were wound healing issues. They are an absolute headache for surgeons because of their massive size, the complex repair required, and the frustratingly high risk that they'll just come back again.
Section 6. Recognizing severe complications. Knowing when to act fast.
Figuring out the anatomy is great, but your absolute #1 job is recognizing when a hernia is turning into a surgical emergency. Look at how the stakes escalate here. You start with a simple, reducible swelling, low risk. But if it becomes irreducible, meaning you can't push it back, the risk goes up. If it gets incarcerated, meaning it's trapped tightly at the neck, the risk is high. And if it hits the strangulated stage with acute pain and skin changes, that's a full-blown ischemic emergency, and they need an operating room immediately.
And remember that incredibly tight femoral canal we talked about? Because of that narrow, unforgiving neck, femoral hernias carry an insanely high risk of bowel strangulation. So here is your golden rule. All femoral hernias should be surgically repaired. If you find one, you act fast, and you recommend surgery. No exceptions.
I want to leave you with a phenomenal clinical pearl from our source material today. It goes like this. A swelling with a cough impulse is not necessarily a hernia. A swelling with no cough impulse may still be a hernia. You can't just rely on one physical sign. Trust your training, follow your step-by-step exam, always check both sides, and know your anatomy cold. So the next time you're examining a patient, are you ready to look beyond the obvious symptoms and truly trust your clinical investigation? Thanks for joining me on this explainer. Keep learning and keep asking the right questions.